pension is actually being managed through the Taifa Pension Fund. There are hundreds of retirees who are actually right now enjoying their benefits being paid by Taifa Pension Fund. Optimum interest rates guaranteed. Claims are settled within 14 days. 24/7 support through online portal, and easy onboarding, and also easy clearance. TaifaPensionFund.com. Go there. We're having a conversation about new risk. It's not a new risk. It is the acronym for Novel Extreme Weather Risk Insurance System for Kenya. And this is the new research that's been conducted by a team of scientists from Kemri Wellcome Trust in collaboration with the others from Oxford University. The team from Kemri Wellcome Trust are here: Moses Kitty and Sharon Onyango. Kenya experiences diverse weather patterns, periodically leading to extreme weather events such as floods and drought. The nature, frequency, intensity, and distribution of these has been changing over time. In last year alone and this year, Kenya experienced extreme flooding in 40 of our 47 counties. This led to deaths, displacement, and infrastructure damages, including more than 60 health facilities. So what do we need to do to understand the impact of this extreme weather on our health facilities? What do they need to do to prepare for these extreme weather events, because they're happening more and more? And this is where the insurance part comes in. Yes? Yes. So one of the things that you're talking about in this research, Sharon, is you are going to look at health facility assessment. And you mentioned this briefly, but just go straight into it. In this research, no. The first question was going to start with, where are you in this research? And what are the next steps?
Okay, so we are in the first stages of this. We just started the project this year.
Okay.
So we're in the very preliminary stages of it. The different work packages have different tasks that they're going to deliver. So for each work package, there's a bit of work that is ongoing. We are particularly in work package 2. So as I mentioned earlier, we are currently doing scoping reviews. Our work package 2 is for population vulnerability mapping and assessment. So we're currently doing scoping review around this to see what type of specific weather events that are affecting Kenya, which populations are mostly affected. So for work package 3, they are working on assessment of health facility preparedness. So it's also work that is ongoing. So the timeline it's about 4 or 5 years, if I'm correct. So for now, we're just in the preliminary stages. I think as time goes by, we will be able to disseminate and give quantitative feedback on this.
Oh, will you only be focusing on health systems? Because then, when people hear extreme weather and the vulnerability and the impact on populations, for example, very many questions are coming in. So, for example, what we saw flooding in Marsabit, does it mean that people would have been able to repopulate their livestock? Is your research going to focus on the impact on the health systems and the health of the populations?
Yes, it cuts across both. As I've mentioned, the different work packages work on specifics. So work package 2 is for population, work package 3 is for health systems. So all of it, we're going to be doing it together. And it's for the entire country. As you've seen, we will take it for the scoping review. It's for Africa, and then taking it all the way to Kenya within the specific climate zones. So we've also narrowed down later. We will be narrowing down to Kisumu, Kilifi, Kirinyaga, and Turkana to get to see at a downscaled, micro-scale level what are the type of vulnerabilities that are experienced by these populations as well as the health systems.
Sorry, go ahead.
You need to come in.
Yeah, I can also add on what Sharon has said. I think 2 major things that we expect as output from this research. One of them is we are also going to do some climate modeling work to understand how has it been in the past and how do we project it to be in the future, so that you can see if you're talking about understanding vulnerability, we're looking at the impacts in the future. We're not talking about what has happened in the past. So we want to understand what happens next. What if a flood happens in this area? Who are the people who are there? Which health facilities? How have they been designed? And how can we ensure that we put necessary measures in place so that they are not affected as much as they would have been if you had done nothing at all? The second thing, and this climate data can be used across different ministerial agencies or any other people who want to use that data for similar work. The second thing is a vulnerability analysis. So yes, we are focusing on health, but it's something that can be used by many different agencies. Again, if you understand which people can be most affected by a disaster, then that gives you a very large playground that you can work with. For example, if you think about if there's an accident somewhere and you know this is the type of road that is there, these are the people who are living around this area, they are disabled people, they are elderly people, then you know specifically what kind of help are you going to take to that area. I mean, if people are on wheelchairs, you need to go with, people are disabled physically, for example, then you need to go with facilities which can actually help to evacuate them from that particular area. So in terms of risk management and emergency evacuation, even planning for agricultural relief food, for example, then this can actually be used across very many different sectors done by the government.
How did you determine to work in Kilifi, Kirinyaga, Kisumu, and Turkana?
Good question. So we've already done some preliminary climate modeling work, and what we wanted to actually see is which areas are undergoing what you're calling climate change. So for example, which areas have exhibited increases in temperature, for example, if you're looking at now compared to what has been happening in the last 50 years, or which areas actually have more frequent and more recurring flooding scenarios, such as in what is happening in Kisumu. Again, looking at it in terms of where we expect to find vulnerable populations. For example, in Kilifi, we know and understand that poverty levels are high, social economic status are low. We also have a very good platform in Kilifi that colleagues who have come before me have talked about. We have a health demographic surveillance system that has been monitoring people over a period of time. I think over 20 years now, that you can use as a basis to actually understand more the impacts of climate change that has been happening over time. Same for Kisumu, we have a similar system. But a place like Turkana, that's a bit far off. It's a bit understudied, I can say the same. And these are places where we actually do expect also to observe high vulnerabilities compared to other areas that are there in Kenya. So we were looking at areas which have exhibited different climatic changes, areas with different potentially kind of vulnerabilities, areas which will potentially require us understanding the situation, and we can generalize that to other parts of the country that have similar populations or social economic statuses. And
Why
now.
Kirinyaga?
Let me try to remember. I think Kirinyaga is experiencing different kind of conditions compared to these other areas that you have. Okay. I think one of them is, in addition to that, we have facilities whereby it is potentially easy for us to go into because we have some rapport with some of the medical personnel working in these areas. We also identified this based on our climatic change map that we have done. So looking at areas which are potentially going to experience an increase in temperature over time. So that's why we think that it is important to do that. Again, at the same time, this is an area that also experiences very low temperatures. And if you have an increase, then it's going to actually have an impact on the population in the near future. So that's why Kirinyaga is also interesting to us for us to study. Yeah.
It's interesting as you do the study and as you do the research and say, okay, well, these are the patterns that we see. And based on that, then we're going to probably be able to benefit from this kind of intervention, in this case being insurance, right? But then it also strikes me that there would need to be the resident infrastructure upon which this would sit. And whether that's at a government level, whatever, would it need to work hand in hand with resident infrastructure, existent or non-existent, to ensure that then the results of the research then are not wasted? Because I can say Kirinyaga, Turkana, it's necessary for me to have it. But if I don't have a receptor, then it's difficult, isn't it?
True.
So how do you go about, how would you envision going about that?
Yeah. One of the things that we did earlier on is a stakeholder mapping exercise. So we looked at different entities. I think we've had communications with the Council of Governors, we've had communications with Kenya Meteorological Department, and direct communication with the Ministry of Health in the various countries that we intend to work with, and also in consultation with the Ministry of Health in Kenya. So these are individuals who have also expressed interest based on what they perceive as their needs for us to go and work in their counties. So yes, there are existing infrastructures. As researchers, what we know is what is on paper, and most of the times what is on paper is something that have been documented in the past. So now we want to go in and understand what is actually on the ground from our researchers' perspective. The WHO has developed tools that we can actually use to assess these facilities, but working with stakeholders, working with communication experts, other health systems experts, we want to modify these tools so that we can actually capture what is contextual for our country, rather than having a very generic tool that may not really work for our situation. Then that is what now gives us guidance that when we go in, we will actually be able to capture data and process information that will be very relevant to the counties that we will be working in. Yeah.
You know, the thing about research is it seeks to answer or respond to certain questions. What was your question?
Our question is, the basic question is, can a risk insurance system, can a risk insurance help our health system? That is a basic question. Yes.
Valid question.
No, it is it's an extremely valid question, because it looks like climate change is with us.
Yes, it is.
And the extremities that we're speaking of. But then there are those who say that some of these changes we are seeing are not really new. They say that the fundamental difference is that they are occurring a lot more frequently than they did in the past.
And more severe.
That seems to be what some people are saying. So does this therefore then lend credence to everything adverse that we've heard said about climate change, and how it is that we as human beings are directly responsible for the harm that we are now facing?
Yes, it does. And as human beings, we are directly responsible, because about over 80% of what we are now seeing as impacts of climate change are actually brought about by what man is doing in the planet. Burning fossil fuels, like traffic, deforestation, and such kind of practices which are actually detrimental to the environment. So yes, we have had extreme weather events in the past. I think that is very true. What we are now seeing is, as you've said, increasing in frequency, increasing in magnitude, and we, from projections that have been done by climatologists, we're actually seeing that this is going to happen more and more in the near future. As you've seen, I think in the last 2 years, or actually in the last couple of months, we've had wildfires in the US. We've had very severe flooding in Spain, for example. We've had cyclones happening in Mozambique, just our neighbors here. So these are things which used to happen, but not as much as they are happening right now. And the destructive force that are actually impacting on the humans is actually more than what it was in the past. Yeah.
There are many fears that the output of your research will come out with data and information that shows that our health systems are ill-prepared, our communities are ill-prepared to handle adverse effects of climate change. And this therefore will mean that insurers will then say, well, I cannot take up this because you're higher risk. Your risk then is higher. That makes insurance more expensive. Instead of it now being of benefit, it becomes an eye-opener to those number crunchers or the insurance companies who now start saying that you're more at risk?
That's a valid point, and we acknowledge that. And I think what we will want to say is, when we talk about insurance, it's not just about the financial aspect of paying premiums to a company to help you mitigate against future things that may happen. So there are other insurance things that can happen. I think we use insurance broadly, but there are many aspects which Sharon had alluded to that you can actually also implement. Like, for example, if flooding happens and there's an outburst of diseases, can you take additional health practitioners to go and assist the situation on the ground at the moment? If you are experiencing heat waves in a particular facility, can you improve the infrastructure in such a way that it makes it more comfortable for the staff working there and the patients coming in to be able to sit and get attended to that particular time?
It's a mitigation and planning measures.
Exactly.
So the information here should help the planners to know that this is what's likely to happen in this area. When the weatherman says expect the rains to do this and the other in the month of October, November, December in this area, then those who are involved in various departments will know that these people are therefore more vulnerable, and we need to look at how to get food to them. We need to, how to send in more health workers there. We need to. This is what it help. This is what it'll help.
Yeah.
Okay.
Yeah, and just to add also, remember we're looking at also two very extremes in our economic modeling.
Yes.
What happens if you don't do anything versus what happens if we do something? This something, I think, is something where we are still working on to determine. But in between these two extremities, there are very many other possibilities that can actually come into place. And this is what we'll be looking at in the models and seeing which can potentially be the best outcome that can be implemented by different development partners.
So from what I understand about research sometimes, Sharon, is that even when you're starting and you're looking through and looking at all the different details, you imagine a situation to which this research would be applicable, right? And you can see it playing out in your mind and say, okay, look, this is how it would actually be if we applied it. Let's take the floods that happened in Kenya, 2023 into 2024. If this would be applied to that situation, what would we have seen that would have been different with the application of these findings?
Okay, if maybe I would say that an example would be in the health workforce systems. So this is still in line with when you're doing research, you have to use some guidelines, which now the WHO give on vulnerability assessments. So in terms of maybe the health workforce, how maybe what type of need, or maybe what type of how do I put it? What type of health workers would we need? If it's nurses, if they're overwhelmed, would they need assistance, like ward assistants, to help, assuming maybe an outbreak of cholera, or assuming maybe the different vector-borne diseases that come as a result of these extreme weather events? Do we need more workforce in terms of adding more nurses, adding more doctors? Do we need to have, as he mentioned, as Dr. Moses mentioned, do we need to put our infrastructure in place in terms of maybe if it's during the heat or during when there's like high drought, there's need for ventilation, which could actually in turn incur high energy cost. So do we need to work together with architects to help redesign these hospitals and such interventions?
There is risk. There is insurance that deals with what we're discussing. It's called catastrophe insurance. And if you look at the list of what they insure, it's actually interesting. Hurricanes, floods, storms, earthquakes, volcanoes, imagine. Now, just with this in mind, if we are looking at, because what we're looking at here is something that is going to occur more frequently with time, as we've observed. Everything else that I've mentioned here have their cycles, but the cycles were far and few between. They were not an everyday occurrence. When you look at what it is that you are seeking to study, or the question you're seeking to answer, against insurance that already exists for catastrophes? Because what we're discussing are catastrophes. Can lessons be learned from where these things have been applied to our country? Because I'm not certain we have those types of insurance in this country. I'm not certain. I don't think we have them.
Well, no, we don't have. No, we don't have such in Kenya. That's why, taking it from an example of the agricultural sector, they already have a risk insurance for maybe their livestock, which actually is in place and it's working. But there's none particularly that can curb or help us work around these catastrophes, specifically for the health sector.
So they have life insurance for cattle.
And for me,
More or less.
more or less, yeah.
Yes, they do.
When it comes to the consumption of the research, right? So you expect that it should be taken up by those in offices that have a responsibility, but also should communities also get this research so they know that yes, this is what has been said. If we don't do anything, if nothing happens, this is the risk that we face, and if something happens, some of which we can do ourselves, this is how we can save ourselves. How do you ensure that the communities that you're actually going to research on get this information?
An important thing that we are doing is what we are calling co-creation. So as part of our work package 3 that deals with the community directly, we're actually, first of all, is engaging them as we are planning the research to understand what they consider as important to them and what they actually think will potentially work for them. This will also include disseminating first of all, seeking to understand what they know about climate change and how it has an impact on them and their health.
Yeah.
Then, as we are having those conversations with the community members, we will also be disseminating to them that this is what we know. We now know what you know, and there are other things that we can add onto this conversation. So this is what it is: climate change. This is how it will affect you. And as we're discussing about this and taking into account the indigenous knowledge that they actually do have about what they have actually been doing in the past to minimize the impacts of adverse weather events, then these are things that we can actually potentially incorporate into our own thinking, into our own economic models, and have them and propagate them and see. We have our own thoughts. But if you account for what the community thinks and what they actually do prioritize, then we can actually come up with a hybrid system that is acceptable to the community members,
Right.
that is actually practical and works according to what we have seen from our model outcomes.
Yeah.
And we can actually now introduce this to various agencies. I think we've mentioned that we are working closely with the Council of Governors. So these are people who have already given us their buy-in in terms of the research. So we're hoping that we're having these conversations with them, and especially health being a devolved function, we're hoping that we actually have the buy-in from the start. This is what we are studying. This is what we expect to get. This is what we now have. Let's now have another round table. We present our findings. Then we discuss what do you think would actually work for you, given everything that we do have, especially the obligation to be paying money to the insurance company to cover you, because that is definitely a very huge thing.
It's a big conversation.
Yes, it is.
Dr. Moses Chapakiti, researcher at Kemri Wellcome Trust, and Sharon Onyango, research officer at Kemri Wellcome Trust, who are part of a team conducting a research on the novel extreme weather risk insurance system for Kenya. They've been our guests. Keep it here for more. It's 9 a.m.
Create timeless memories